Welcome back to Rural Health Summit, a season of Rural Health Today. In this season, we're sitting down with a series of guests at the MHA Annual Summit meeting, where many healthcare executives and leaders across the state meet to review the last year of collaborative efforts and the work that we've accomplished. In each episode, I'll ask my guests to give us an update on their hospital or healthcare organization and to touch base, so to speak, on the healthcare issues they see that is most pressing in their corner of the rural health world. It's great to be in our mobile studio because we took it on the road. Each year we go to the Michigan Hospital Association's annual conference and we interview aspiring new leaders in healthcare. And I have today with me one of those who is making a name for himself in a very beautiful part of Michigan. We were just up there for Tulip Festival, or the preamble to Tulip Festival, I should say. And it's great to have today Executive Vice President, Chief Strategy Officer at Holland Hospital, which I'm going to learn about in just a minute. I believe you're like me. I believe you're still independent. We're going to talk about that. Okay, good. So Alex, talk to us about your healthcare journey, what you do there, and then Holland Hospital in general. Talk to us about the hospital.
Absolutely. So a little bit of background about myself. I'm from Holland, Michigan originally.
Oh, that's nice.
I know a lot of times you'll have interesting facts from your guests.
Absolutely.
An interesting but embarrassing fact about myself is I live in the same neighborhood I grew up in that my parents also live in. It's about like 25 houses in total, and I've now lived in 4 of them.
Are you serious?
So, I don't branch out too much.
I was going to say, you don't branch out too much at all. So what community is that?
It's on the south side of Holland. It's
is
called
that right?
Scenic Shores.
Okay. Yeah. Mm-hmm. So very small community, grew up there, went to college where?
I went to University of Michigan
okay.
Undergrad and then a master's of accounting there.
That is incredible. And then your journey started in healthcare when?
It started in healthcare about 15 years ago. So I was in public accounting for a couple of years.
Thanks.
And yes, exactly. It was a great experience in terms of working with great people, learning a lot. But it was just what I struggled with is finding meaning in what I did.
Yeah.
The purpose of public accounting is to allow investors to have confidence in the financial statements that a certain company is producing, which that's needed, but it is not something that provides a lot of meaning.
Right.
Yeah.
Right.
So I actually intentionally, when I was in public accounting, asked to get into the healthcare sector. So I got to audit different hospitals, health systems, even long-term care organizations across the west side of the state of Michigan, because that's where I knew I wanted to end up, because you can actually make a difference then in the community.
So you knew early on you wanted to get in healthcare?
I did. Not when I went into public accounting initially, but
after you started interviewing and working with these companies.
Yeah.
So your first healthcare job was what?
It was as a financial analyst with Spectrum Health at the time in Grand Rapids.
They're my favorite positions.
Yeah.
I love
financial analyst is a great position.
Reimbursement analyst and financial analysts are phenomenal.
Yeah.
They are the meat and potatoes of our business. So you did that.
Right.
And then what happened after that? You went somewhere else.
Yeah, so my wife and I were living in Grand Rapids at the time, and then a house in the neighborhood I currently live in and grew up in opened up in Holland, and so we jumped on that opportunity, and that was always my long-term vision. I just didn't know if it would ever work out. Holland's not a huge population.
Right.
To be able to have a job in a role that I was interested in back in that community. Yeah. And as soon as that opened up at Holland Hospital, I jumped on that and have been there ever since.
Yeah, and you've worked yourself up into some pretty significant roles. The one that you hold now, we'll talk about in a minute, Chief Financial Officer at one point.
Correct, for 5 years.
That's significant. I mean,
thank you.
CFO role in today's age of COVID that you went through, I'm sure, and all the federal programs of reimbursement. You had to navigate that, and Holland did very well. But ultimately, you landed at your new role, which is strategy.
Yes.
All right. So wait a minute. So a finance guy goes into strategy. Talk to me about that.
Yeah, and that honestly was not on my career path that I had envisioned, and it was something that came up fairly recently. I've been the CFO for the last 5 years and moved into the Chief Strategy Officer role in February of this current year.
Yeah.
And that came because our president retired and our CEO wanted to get some experience from the outside in the strategy realm and started to look around. And there's some great candidates, but something just wasn't quite sitting right with her.
Yeah.
Actually, an individual that I had worked with in public accounting had applied to the position, and he had worked in strategy at some other healthcare organizations.
Yeah.
And as our CEO, Patty Van Dort, was thinking about it, she realized a lot of the work that we're looking to do within the strategy realm, I was already doing a lot of that just naturally in the CFO position, which is really just connecting with the community.
Yeah. So you've been doing it for how many months?
For, I guess, 4 months now.
And how's it going?
It's going well. There's a lot of transition as we move things to our new CFO.
Oh, true, because you're probably still kind of doing a little bit of both.
There's just so many annual things that come up once a year.
Absolutely.
So we're in the transition phase, but he's a very quick learner, and it's going really well so far.
So, Alex, you were involved in I heard your name used by MHA on numerous occasions because you were advocacy in 340B.
Yes.
For our listeners today, explain 340B and why it's so important, and what are you doing as a hospital to maximize that program? So what is it? What are you doing?
Yeah, so 340B is a federal program that allows certain types of healthcare providers. We qualify, Holland Hospital, as a disproportionate share hospital, or a DISH hospital, meaning we have a disproportionate share of our inpatients that are on Medicaid, essentially. And what this does is it allows us to purchase drugs at a discount from what we'd otherwise be able to purchase those drugs at.
Right.
And this is the federal government's way of recognizing that essentially Medicare and Medicaid underpay hospitals.
Yeah.
And so to stretch scarce federal resources, they've allowed hospitals to purchase those drugs from drug manufacturers at a discount, which is brilliant. It allows hospitals to save money, but that money's not coming from the government itself.
That's right.
It's coming from the drug manufacturer.
I think that's a misnomer right now because, Congress and even certain members of the community think that 340B, I'm paying that on my taxes.
Right.
And congressional leaders think that that's government. It's not.
Yeah, there's no government dollars that are paying that. Absolutely.
And if you looked at the profit margins of pharmaceuticals, they're doing a lot better than healthcare today.
Yeah.
So you've been an advocate for 340B, but how have you leveraged it at your hospital?
Yeah, we've leveraged it in a number of ways. One thing that we've done fairly recently, 2 years ago, we opened up a specialty pharmacy, and this was just born out of necessity. So we were losing access to 340B drugs because of some unilateral actions that the drug manufacturers were taking. And to really take matters into our own hands, we had to open up our specialty pharmacy to secure that access.
Yeah.
And really, that's been a godsend to us. It's allowed us to retain that access, but then find new creative ways to help keep new programs within the community, and then also find ways to bring discounts to community members.
Yeah.
So for instance, we're working with a number of employers that we have a certain arrangement with them where we can, if a prescription is written by one of our providers, it's 340B eligible. And if it's filled by one of their employees, our community members, at our specialty pharmacy, we're able to make it so there's no copay and no deductible.
That's incredible.
So yeah, really benefiting the community members on their savings, and that helps with medication
But
adherence.
Alex, we take that money and buy cars and jewelry and build expensive buildings. But that doesn't happen.
Yeah, that certainly doesn't happen.
You're returning it back to the community, what it was intended for.
Exactly.
And so in your advocacy efforts right now, you know that it's on the chopping block.
It is, right.
So what advice and advocacy would you give to our listener today about what they can do?
Yeah, I would just ask listeners to do their research on the 340B program. And you mentioned the profit margins of the drug manufacturers. They're certainly different than what we see in the healthcare industry with hospitals specifically. Yeah. And I think that tells us enough there that this is not a play over what's good for the community. It's a play over what's good for the bottom line for manufacturers. So really do your research.
Do your research.
And also, please reach out to your representatives.
Right.
Actually, from the hotel just last night, I sent an email to Senators Slotkin and Peters, the two senators for the state of Michigan, asking them to support the bill that is being brought forth by a senator in California, pushing back on the actions from Eli Lilly. I'm not sure if your audience is familiar with that, but they have decided, Eli Lilly, to cut off access to hospitals that are not submitting patient information to Eli Lilly. Yeah. And if you haven't done that, including my hospital hasn't done that, because we have concerns about sending
confidentiality, the whole 9 yards.
With no
What's that information being
non-disclosure
utilized
agreement,
for?
no understanding of what they're going to be doing.
But it's
with
one of
that
the
data.
tactics and games that they use. They tried to deploy the voucher method. Now they're doing things like this, really to distract, and they don't want to pay as they should pay. And it's critically important that if you're listening today, be an advocate for 340B as a 340B hospital. All right, let's talk about some other challenges because the political landscape today is very rough.
It is.
There is a lot of Washington legislation and a lot of Lansing legislation that's going to negatively impact hospitals in our margin. I guess I'm going to ask you, strategy officer, what are you doing and what strategies are you deploying to ensure the success of your rural hospital? Because let's pause there before you answer that. Give our listeners a sense of the size of your hospital, because I think that's important to talk about It's not a critical access.
It's not a critical access.
You
Correct.
are in a market that I'm surprised that you have a disproportionate share, to be honest, because you're in a region of the state that I think you'd have high commercial, but you must see from surrounding areas, I would assume.
Correct. That's exactly right.
Okay, so you're seeing that. And so in your environment today, Holland is an independent hospital. 300, how many beds?
191 beds.
191 beds.
Yeah, independent community hospital. As of last week, that's down to 6 within the whole state of Michigan.
I know.
And just for context, if you look back 20 years, just in the area that we serve, which is essentially just Ottawa and Allegan County, we branch out just into the very western border of Kent and the very northern border of Van Buren. 20 years ago, there were 9 independent community hospitals in existence, not critical access. Now we're down to 6 in the entire state.
We're in the minority right now of hospitals that are still independent, and I believe we have a purpose and a passion to continue that.
Absolutely.
And so I see that passion in you. But given all of that, right? So you're a hospital that's what I'd call a mid-sized vital hospital. You're not a big center, tertiary center, but you're not a critical access. So you're mid-sized vital, serving a critical role in your community, probably one of the largest employers.
Yeah, the third largest within the city
in your community. So what techniques, what strategies are you deploying to combat the future impact of these Medicaid cuts? Because I'm sure you've heard of HR1 as the CFO previously.
Oh, yes.
And working with your community, how are you doing that? There's work requirements, there's all these things. How are you navigating that?
Yeah, we're really trying to focus in on keeping as many people enrolled as Medicaid as are eligible. And, the work requirements are going to provide a lot of challenges for the community, which is frustrating. And I've heard you talk about this. You can't live off of Medicaid benefits. They don't pay your rent. They don't buy groceries. They're there for healthcare, and they're there for healthcare when it's needed.
Absolutely.
And we're concerned that these work requirements are really going to be just paperwork requirements. And we'll see people drop off the Medicaid rolls because they either didn't know they had to fill out the paperwork now every 6 months. They don't know how to do it. They don't have the resources or the time. So that's what we're trying to...
Literacy issues, the whole 9 yards.
Absolutely. Yeah, and we have a fairly large migrant population within our area and the surrounding communities, and that's a big concern for us. So one thing that we're immediately doing as an organization is we've long time partnered with an organization called First Source, and they have an employee that makes the rounds at our hospitals, and we pay them to do this to help check in with patients that don't have insurance and see if they would qualify for Medicaid. And if they do, then they assist them through that process.
Now, is this in collaboration with the Department of Health and Human Services, or no?
This is separate from that.
This is separate.
Yeah, we're looking into that collaboration as well.
Yeah, we have the MDHHS, but this intrigues me. Tell me more.
Yeah, so First Source is the organization that does that, and
so anytime you identify a patient without insurance,
correct,
you will send them up there.
Yes.
Wow.
And now we're starting to invest further into that resource so that we'll have a representative from First Source not just available at the hospital. They will be available at the hospital now all days of the week. Currently, we have not had that, but also at physician offices or non-hospital locations to make sure we're reaching the full community and the people where they are, not just when they're sick, but hopefully when they're with us getting preventative care as well.
Are you going to try to do that on your own? Or are you partnering with this company, or are you going to try to mix it?
Yeah, partnering with First Source, but we also realize that even that's just a small bit of what the community needs as a whole, and we can't do this on our own. So we're really reaching out to community partners.
Yeah.
A key one that we're working with, there's a fantastic nonprofit in our area called Community Action House. They're essentially a food pantry. They call it a food club, and they have members, and basically their entire constituency are individuals that qualify for Medicaid. So they already have resource navigators on site helping people sign up for SNAP benefits, for Medicaid, for other programs as well. So we're working with them in collaboration to help make the community aware of the resource navigation they have. But further, we do believe that even despite our efforts and despite Community Action House efforts, there are going to be people that lose their Medicaid enrollment and are not going to be able to afford commercial insurance. Yeah. So what we're doing at this food club is we're going to be putting a Holland Hospital provider on site and available at no cost, no copay, no deductible, nothing billed to insurance for the food club members.
That's amazing.
And, what's in it for us is really nothing other than trying to live out our mission. Our mission is to improve the health of the communities that we serve in the spirit of hope, respect, compassion, and dignity.
Man, that's good. Good job to you. That's amazing. So that means it's passionate. If you can remember that, it's coming from the heart, and you're serving it out every day.
Absolutely.
In that population that you're serving. All right. So let me ask you. We talk about good things. We talk about bad things. We got to talk about bad things. Federal legislation is very bad. Recently, Michigan introduced some bills. I don't know if you follow that or not.
Yes.
Those are dangerous. Talk to us about what the impact of something like that would be to your hospital, a 10% reduction, in payments.
Yeah. I mean, that would be devastating to us as an independent community hospital. Our operating margin last year was 2%. And
congrats. That's good.
That was the best one we've had in
Congratulations.
6 years.
Because that's a good operating margin.
Yeah. The past couple of years, we were at 0.2%.
Congratulations with that.
Negative 2%.
Yeah, that's what most of them are.
Yeah. And already this year, we're back down to about 0.2%. So if you were to cut our pay by 10% and pay in terms of what we're getting paid for the care that we provide, that puts us in unviable position financially.
Yeah. So your job in strategy, but do you have a job in advocacy? And what is that relationship between the two?
A little bit, yeah. We certainly are not as involved in advocacy as you are, and you're truly one of the leaders within the state. And we're blessed to have you within the state of Michigan doing the work that you do.
Thank you.
But we have really started to step out in the last couple of years to get more active in advocacy, working with our local representatives, also at the state level, to try to tell our story. We believe that independent community hospitals play a vital role. And we're unfortunately a dying breed.
We are.
We need to have that story heard. And we need the lawmakers to hear that story.
Preach it, man. I think I found my co-host for my podcast. I'll talk to you about a contract later. So as you face these challenges, the CFO in you is always worried about the margin. My CFO tells me every day, no margin, no mission.
No mission, right.
And I didn't understand that when I was in operations because I'm like, no, we need to spend this money. We have to do this. We have to do that. Until I became the CEO and I'm like, oh, I get it. And so we have to make a margin at some point. We have to invest in technology, our people, back into the community because you give community benefit, right?
Absolutely.
Significant amount of community benefit. You have probably every group comes to you for donations. And so you face the same challenges. But I want to ask you, you had a previous role CFO, now you're in strategy. What keeps you up at night as you think about all these things? Like what's the number one that you're going, you look over to your wife and you're like, I'm really worried about this.
Yeah.
What is it?
Honestly, it is the Medicaid disenrollment that's going to be coming. That is just going to put us in a very challenging position. There's always going to be challenges in the industry. Site of care is something that we've been dealing with. Site neutrality might be something that comes down federally at some point in time. But 340B is always on the chopping block, as you mentioned. But really that Medicaid disenrollment jeopardizes a lot.
It sure does.
Our community is still going to need the care. Our concern is that they're not going to get that preventatively. Instead, they're going to show up in our emergency room when things are more acute and it's more costly to provide that care, and they won't have insurance at that point. And we're not going to turn them away. We're going to make sure they get the best possible care.
Right.
But it's expensive to do that. And on top of that, as a disproportionate share hospital, we have qualified for a long time as a DSH hospital. But as you mentioned, our area is not particularly known as an area that you'd think we'd have a large indigent population. And if you see significant disenrollment, then that jeopardizes our ability potentially to remain eligible for 340B.
340B and significant. And not only is 340B on the chopping block, but if the average commercial rate goes away, what happens with DSH? Do we get it back?
Right.
Disproportionate share. And then you've also got LVA. I don't know if you qualify for low volume adjustment.
Yeah,
but
we don't.
We're a hospital that we do. And that to us is a significant impact. Well, all right. So that's all the bad news, right? And what excites you about what you're doing right now? Whether it's you individually, give me both, you individually and Holland Hospital. So your role, what excites you? And then what excites you about the future for Holland?
Yeah. And honestly, I think the answer to those is going to be the same.
Okay.
In my role, part of why I made this move to the Chief Strategy Officer is because of my ability to get more involved in the community. I was doing that as employers are reaching out to the hospital about direct contracting, et cetera. And we've just been getting more involved in not necessarily just the direct contracting piece, but looking for ways to meet the community's need in a cost-effective manner and build relationships so that we have actual relational care.
Absolutely.
And not continuing towards the large system type of feel, but really getting back to that community-based care. And that truly excites me because there's some exciting things that I think we're on the precipice of that can make a difference and bend the cost curve, but just as importantly, actually make a healthier community.
Yeah. Wow. Incredible work you're doing. Incredible work. I have followed you and the work that you've done. I'm pretty excited for what's going to happen with Holland with you and the strategy.
Thank you.
I think some great things. I would encourage you to continue the relationship with MHA. That is so critically important.
Absolutely.
There's some great people there. And then when you think about strategy, independent, right, as a hospital, but we don't put sandbags around ourselves. We're interdependent.
Right.
So the Hollands and the Hillsdales and the Oak Lawns, the very few of us that are left need to come together and have, meaningful dialogue. It's a WASO, in their community, having dialogues about how do we sustain rural health in this country? Because I'm going to tell you, tertiary centers don't want us. They want your attributed lives, but at the end of the day, they don't have capacity to meet. They're already staffing ratios are low. Their ERs are overwhelmed right now. They can't serve properly. We need community hospitals today, more than we ever have before. But yet 174 on the immediate list, 734 are on the at-risk list. That's us. And we have got to advocate and be a voice.
Absolutely.
In that vein, then, the last question I'll ask you is, you have young aspiring leaders like yourself that are rising up in a very tumultuous environment today. What rural health recommendation would you give them as a leader to continue keeping on, and what sage advice would you offer?
Yeah, I thought about this in advance, since I know this is a question that you asked your interview participants. And actually, I think you almost hit on it already in that answer. My answer to that was going to be, this isn't something we need to do alone. In fact, it's something we shouldn't do alone. And I think the reason that our institutions are still independent is we've been good at partnering. We're not trying to be everything to everybody. We know with our community sizes, it doesn't make sense for us to have, say, an open heart program. Even if we could get the providers to do that.
And the CON to do it, but you just have the volume
to keep them skilled at doing it. And that's where we need partners. And I would suggest that anybody in our positions or similar positions find partners that have aligned values and work together to find those win-wins, because they do exist. And that's necessary for us to continue to provide the care that we do for the community.
Alex Roehling, Vice President, right? And Chief Strategy Officer. That's awesome. Holland Hospital, independent hospital in a beautiful location, Holland, Michigan. It's been great to have you on this series. I'm going to get you back for a full podcast at Rural Health Today. Okay,
I love that.
This is kind of our intro of you, but I think you're going to do some great things, and I would like to come back and talk about 340B if we could specifically, to really break it down in some get in the weeds. We need to get in the weeds to educate our communities and our lawmakers. We just found out last week that one of a very well-known legislator in the state of Michigan listens to the podcast every week. We got that confirmation from her in a text message. And so we know that there are legislators listening to this and across the country, not just in Michigan, but we have the most, to gain by leveraging Michigan legislature. But I want to get you back to talk about 340B and some of the programs, and then to talk about how would you duplicate strategy across the state of Michigan for small rural hospitals. You willing to do it?
I would love to do it.
It's been great to have you here today. Thanks for joining us.
And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so that you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.